Welcome, everybody. I'm Kathy Tam, the Director of Professional Programs and Education here at the OPA. Welcome to today's webinar, COVID-19, not just another respiratory disease. I'm very pleased to have Dr. Peter Lynn here today to speak with us about this very interesting topic, as you'll soon find out. And first, I do want to thank Pfizer Canada for providing us with an education grant to support this webinar. Before we get started, just a couple of housekeeping things, and just to share a couple of OPA resources and education opportunities that we have. I do want to share, since we're talking about a respiratory condition, that we do have the Respiratory Illness Therapeutics Support Line available for healthcare professionals. This is available. There is staffed by registered pharmacists every day, 7 days a week from 10 to 6 p.m. You can learn more at opatoday.com/respiratory support. And the other thing I want to share is that OPA is pleased to co-host with the Canadian Foundation for Pharmacy the 2026 Sharp Symposium. Save the date for September 30th. Registration is not open yet, but stay tuned. This symposium, Sharp Symposium, Building an Equitable and Integrated Health System, will be an exciting learning opportunity where we're going to share cutting edge academic research and kind of marry it and meet real life pharmacy practice. So kind of sharing the two, and it'll be a great way to learn more about what's going on in pharmacy research, but also how it applies to your everyday practice. After that day, the symposium, in the evening, we will cap things off with the annual OPA and CFP award ceremony. So stay tuned for that. We will have more information in the upcoming weeks. And if you want to learn more about and find more education opportunities, you can go to opatoday.com/education. Okay, so Dr. Peter Lynn, he's our speaker today. Thank you so much for joining us. Dr. Lynn is the Director of Primary Care Initiatives at the Canadian Heart Research Centre. He was also a contributing author to the Canadian Diabetes Guidelines in 2013 and 2018 on the vascular protection section. He's also the past associate editor for the Elsevier web portal, Practice Update Primary Care. Dr. Lynn has lectured extensively on a variety of therapeutic topics and common diseases such as diabetes, cardiovascular disease, cancers, but also not so common topics such as microplastics and its effects on the body and artificial intelligence. He is has been the co-chair of the Immunizations Across the Lifespan Conference in Canada for the last 4 years. And he was actively following and educating about the COVID-19 pandemic right from the start. He reaches out to the public with his role as a medical contributor to the Canadian Broadcasting Corp, CBC, and he has received an award from the College of Family Physicians of Canada for excellence in medical education. Thank you so much for joining us, Dr. Lynn.
Thank you very much, and thanks for the time. And I love your graphics and everything else. Let me just try and see if I can share.
Mhm.
I just sent a request. Okay, great.
Yep.
Let me just share my slides real quick. Thanks for those nice words of introduction. I wish my wife was here to hear these nice things about me. Anyway, so maybe I'll be in less trouble. Anyway, but thank you very much for Kathy for all that you do in terms of doing these programs. It's a lot of work, and thank you for making it so easy for us from the delivery. And I thought I'd start off with this picture. It's a beautiful beach. I think we all want to be there. We all want to be in that little Hershey's Kiss right there. We love our patients, but not all the time. So if we keep our patients very healthy, then basically we have a smoother life as well, right? So they don't come and bother you, and they don't come and bother me. So if we can keep them healthy, that'd be good. And vaccination, medications for antivirals, those kinds of things may be helpful. I know it's kind of a weird time to talk about it, but as you'll hear, is preparation is really the most important thing. So if we have things in place, then everything will run much more smoothly. So let's just see here. These are my conflict of interest. So I've worked with all these companies before in education. I don't do any clinical trials and I don't own any patents. And I want to thank Pfizer Canada for allowing us to get together for this program. I thought I'd start off with this with the tariffs and everything else. She is wearing clothes on the other side. So for those that are wondering, so, in Canada, our healthcare system, we spent $400 billion last year. And I know that number sounds a lot, but in comparison to the United States, it's actually quite cost effective. So in other words, in Canada, where our healthcare costs are lower, that's why companies come here to manufacture. because their healthcare costs are lower for their employees. So if we can all do a good job and keep that healthcare cost down, we're actually very competitive in the world. We can keep Canada competitive. And if you think about it, if we could just save 1%, that would be $4 billion. That would be enough money to save the steel industry, the wood industry, the auto industry, and $1 billion left over for, healthcare. And we could do that every single year if we just saved 1%. So if we were able to get rid of some of the infections, that would be good. There are some diseases that we can't control as much, like cancer and stuff like that. But certainly, infectious disease is one where if we can decrease the number of people getting sick or containing their complications, we can save that 1% very easily. The coronavirus, as you know, was a disaster. And I think I have to thank you guys as pharmacists. You guys kept the doors open, whereas as doctors, we ran away scared. So I always thank, my sister and my nephew are pharmacists, and my niece-in-law are all pharmacists. So we always thank them for keeping everything alive and moving during the pandemic. But then we started looking at these people with long COVID, and this is studies that you've seen before where they list the symptoms of long COVID, and you see these crazy things like every single system was involved. And so therefore I got the question, what happened? Like how did this happen where every system is involved? So I said, let's turn back the clock and see when was the person actually healthy. And when the person was healthy was just before the virus attached to the ACE2. Now, everybody knows that the spike protein attaches to the ACE2 and that basically the virus is invited in this way and the ACE2 now comes into the cell. But nobody asked the very simple question is what does the ACE2 do normally? In other words, what's its role? It's certainly not there just waiting for the virus to come in as the key. And so therefore, I just asked a simple question, what does ACE2 do? And so if you go and search online in ACE2, you'll find this particular paper that says what ACE2 does, right? And this was published in 2020, just as the pandemic was coming. And this is way too complicated. And so therefore, in medical school, when there was complicated stuff that I didn't understand, I would just delete them. So it was just a lot easier. So let me just delete everything and just start off with this one. So here's angiotensinogen. This one you know about because you know that renin touches it and then it becomes angiotensin 1. The ACE enzyme comes in and you get angiotensin 2. And angiotensin 2 hits the receptor, the AT1 receptor, and basically that causes the following thing: vasoconstriction, blood clot formation, inflammation, and fibrosis. And so that's why you give a lot of your patients ACE inhibitors and ARBs to block the receptor in order to stop this process in your heart, in your kidneys, in your vasculature. And that's why patients are taking all these RAS inhibitors to protect them. And then I sat there and I said, well, why would nature give you a bad process, right? This sounds like a horrible process that we would have in our body. So why would nature give it to us? This is not a horrible process. This is a repair process. So when you cut yourself, what do you want to do? You want to have vasoconstriction, clot formation, antiseptic, so inflammation to kill off germs, followed by scar formation. So in other words, this pathway is a repair pathway. And so that repair pathway keeps all of our vasculature well when we get damaged. However, most of the time we don't need the repair pathway. So this repair pathway is always on, but we don't need it on because we don't need to do all this scarring. So what happens is that the ACE2 takes all those chemicals and diverts them, converts them into other chemicals, which then goes and attaches to this particular receptor. Now, when it hits this receptor, it does the reverse: vasodilation, no clot formation, anti-inflammatory, anti-fibrotic. So this is the normal state that we're in most of the time, which means the bulk of the conversion is through the ACE2, and that's what gives you your normal state. So as you are sitting here right now, the ACE2 is doing its job, diverting everything away from that scarring and repair process. There's one other thing that I have to introduce you to, and that's bradykinin. So bradykinin attaches to this receptor, and what does bradykinin do? It makes all your blood vessels leaky. So it makes your blood vessels dilate and it makes them leaky. Now, why would we want that? Well, we need to vasodilate so that you send the army to the right location. So let's say you cut yourself on the finger, we need vasodilation there so that we send the blood vessels, all your army cells there. And then we need the vessels to become leaky so that all your white cells can crawl out and then go and fight off whatever invader is coming in from the cut. And so therefore, this is necessary during war as well. But we don't need that in the normal state. So therefore, the ACE2 sort of reaches over and blocks the bradykinin effect. And so therefore there is no leaky blood vessels and all that kind of stuff. So you could see that the ACE2's job is quite large. It's the one that's the peacekeeper. So as long as ACE2 is there, everything is good. You cut yourself, no more ACE2, and then that repair process kicks in. So here's the problem though, in with COVID, it took your ACE2 and it pulled it into the cell. So there is no damage to your cell itself. There is no cut, there is no need for repair, but you remove the peacekeeper. And so by removing the peacekeeper, what you've done is you've taken out the ACE2, which means this diversion pathway is no longer happening, which now means the scarring pathway is on. And so therefore you end up having more vasoconstriction, blood clot formation, etc. And so this is now causing inflammation and scar formation. So this is actually damaging the system because you took away the ACE2 guy unnecessarily because there is no damage there. In terms of the bradykinin system, it is now allowed to go free as well. And so therefore you have this massive rush of vasodilation followed by fluid rushing out. So you get edema and you have all your immune cells coming out of the blood vessel and they're looking for a war, and therefore you create inflammation. And this was really very typical of what we saw in the beginning, right? Because the virus load was mainly in the lung in the beginning when we first met this virus. And so this is a normal lung, this is the normal alveoli, you're exchanging oxygen, everything is good. But then if we do this edema, that fluid, so vasodilation, fluid coming out, your immune cells coming out, then basically all the alveoli filled up with liquid. And what you can see here is they're all filled up, and that's what acute respiratory distress syndrome is, ARDS, is fluid pours into there, it blocks off all the airways, so now you can't exchange oxygen. That's why in the beginning you saw oxygen saturations of like 60% because they couldn't move oxygen across into their circulation. And then what happened if you look at these patients a couple of days later? So this is normal lung on a CT scan. And then you put in this inflammation scar formation. Remember that top pathway, right? So the first pathway is the fluid and everything else. The second pathway at the top is doing scarring. And that's what you see here, massive scarring happening in the lung. And who is this in? This is in a 35-year-old, so relatively young, healthy person. And this is only day 11, and you see all this scar tissue formation. So you could see that when we allow those systems to go uncontrolled, this is what you get: fluid, inflammation, followed by scarring and damage of whatever organ that is. And you can understand that long COVID in this situation, this person is lost maybe 20% of their lung function. And so therefore they're going to be short of breath and so on and so forth. So you might have symptoms of long COVID because the lung is completely damaged in this way. Now, where does the ACE2 enzyme or receptor sit? So basically, it's needed everywhere, right? Because you need to keep that sort of peace everywhere. And so that's why they show you pictures of this and it shows everywhere. You'll see here, lung is sitting at the very top, and this is the first location where this thing comes in. And so therefore, there was a lot of focus on the lung. And but you could see all these other areas, right? The heart, the kidney, the pancreas, the brain, pretty much every organ is up here. But I just circled the ones that were making it into the news. You know, we started to see more diabetes because the pancreas was getting wiped out. We saw people going to renal failure. So therefore they had to be put on to sort of these ECMO machines that sort of filter their blood for them. And the brain, we heard people were in ICU and the brain was being affected as well. But in fact, many of your organs have to have the ACE2 to keep peace. And that was the problem, is that when you look at influenza, influenza uses which receptor to come in? Because all the viruses are the same. They carry a set of blueprints and they carry a set of keys to get into your house. It just depends on which like lock they're going through. So influenza goes through the sialic acid receptor to get into the cell. So there's two important things about this. This receptor only lives in the airway. So therefore, it's not going into your pancreas or anything like that. And number two is that this receptor doesn't do anything else. Like in other words, it's not a peacekeeper. And so therefore, if I took away the sialic receptor, it doesn't really matter. But in this case, we're taking away the most important peacekeeper, and that's why we're having all these complications that we see. The one that they hid kind of small here is endothelium. So endothelial cells have this as well. And it's kind of tiny, but I'll show you how come that's very important in a few slides. I'll show you that. But just keep it in your mind that your endothelial cells also have the ACE2 enzyme sitting on there. At autopsy time, people were saying, like, even though the ACE2 is all over the place, but does the virus actually get into those tissues, right? Doesn't it just stay in your lung and that's it? So at autopsy time, they looked at all these different areas of the body, going all the way down. Here's the brain down here, here's the lung up there. And what they did is anything with a color meant that they found the virus, evidence of the virus being in that tissue. The only one that's negative is the white one. So if you see a white space, it means that they couldn't find it. Anything else is just larger amounts, smaller amounts of viral detection. And so this is what you see. So these patients are within 2 weeks of their COVID infection. And you can see everything lights up, right? So in other words, their lungs are got tons of it, but every single organ system actually has the virus floating around or some remnant of it sitting there. Here is the one that's about out to 30 days. And the one that I want to really show you is this guy. So this guy is 230 days out. And at 230 days out, oh, sorry, at 230 days out. So he had COVID and then he died 230 days later. And what you can see here is inside the lung tissue, there's still stuff. Inside the myocardium, there's still stuff, so the heart. And then over here, this is all brain stuff. There is still viral replication or viral clues that are sitting there. So this is why people are saying the virus is not only able to get in there, but it may be able to stay in there. And there is some concern about neurotissue. Like, for example, when the virus goes into a cell, the antibodies are useless, right? They can't get into the cell. They're too large. So therefore, the benefit of antibodies is now reduced once the virus can get inside a cell. Now, if the only way to kill the virus then is to kill the cell itself. Now, if it gets into nervous tissue, brain tissue, then your body's not going to kill a neuron. And so therefore, it may be able to sit in there for some time. And so therefore, it gets into your brain cells. You're not going to kill off your brain cells, and therefore you may have that brain fog for a long period of time, et cetera, et cetera. So that's why this one is a little different. And we know that the virus can live long in a brain cell because we have shingles, right? So shingles is basically chicken pox that made its way into a nerve cell in your spine, and therefore it could sit there dormant for some time. And then when you get exhausted and stuff like that, you start making, defenses, you start making proteins, you take the blueprints off the shelf, and you start making the virus blueprints as well. And so therefore the shingles can come back. So we know that the virus, once it enters brain tissue, it's unlikely that you're going to kill off that. So therefore, for these people that have like the brain fog and stuff like that, we're worried what happens long term if the virus can still hang out in there as well. And this is why when, you heard politicians saying, just go get the virus, we get herd immunity. That wasn't such a great idea. And also every time you get it, you run the risk of these viruses entering other places. So that's why in the veterans database, when they looked at people that had one infection, two infections, or three infections, they got more and more complications with each infection. So that's why we didn't want old people getting one infection, another one, because each time the virus now has access to the rest of the house, and therefore they can access and set up shop in some of those places as well. In the intestine, you also see a lot of this virus building up, and that's why a lot of times we're measuring sewage because they will be producing a lot of virus in the stool. And so therefore we can use that to monitor active infection, monitor sort of overall viral load. And perhaps some of us may be still carrying some of these viruses around. Who knows? But that's why they measure the stool in sewage as being useful. So now when I show you this picture, this isn't really surprising, right? Because the ACE2 lives in all these different places. If the virus is allowed to wander all over the place, then it will set up shop and cause that damage that we talked about. And so therefore you can have multiple systems being affected. And depending on where the virus ended up in you, that would be the symptomatology that you would be experiencing. Now, remember I told you about the endothelium, to remember that for me? So the endothelium cells also has ACE2 on the cell surface, right? Because it's very important, right? It has to also keep the peace so that there isn't this scarring process, etc. So in fact, there's a lot of ACE2 on your endothelium. And so therefore, if the ACE2 is taken out, then we're going to have vasoconstriction, clot formation, inflammation, followed by scarring as well. So in other words, now we can explain why in the beginning, remember they were doing autopsies on these people, and they said around the lung, there was a lot of blood clots in the microcirculation. And they couldn't explain, like, why would this virus cause it? Because as soon as the virus went across and got into the small capillaries around the lung, they basically did the same thing to the ACE2 and the endothelial cells. And so in all those small circulation, they had vasoconstriction, blood clot formation, inflammation followed by scarring. So therefore, even when we can get rid of the fluid out of the lungs, we destroyed the capillaries. So there was nobody to pick up the oxygen. And so that's why these people died, because they couldn't get oxygen going through. And even if you ventilated them, it didn't help because you blow air in there, but you've destroyed the network of blood vessels to pick up oxygen. And so that's why it was a horrible situation in the beginning in that stage. The other thing that the paper that they put out was that, okay, fine, you breathe in this virus, and if it accesses your endothelial cells, now that's a problem because all of our blood vessels have endothelium, which now means every blood vessel is at risk for doing this vasoconstriction and clot formation. And so that's why we started seeing lots of different diseases in the vascular area. So we had people with strokes that were relatively young. They shouldn't have been having that. We had people with heart attacks. We had people with peripheral arterial disease. We had deep vein thrombosis as well. So this begins to explain why this is happening, because if I take out the ACE2 in your endothelium, it doesn't matter which organ it's supplying, that blood vessel is going to be compromised, and therefore we're going to have ischemia and clots and so on and so forth. So this begins to explain a lot of the young people that were getting these weird complications as well. I like this picture very much. This is what I feel like most of the time. So long COVID was fatigue. And so I got interested in why is it that this one in particular, you're tired? I mean, we're tired with colds and flu, right? But not the kind of tired that we have here with COVID. So even if you just had COVID, we were exhausted just with the acute COVID part. And then the long COVID part, we couldn't explain why people were getting so tired. So it turns out probably it has to do with your power plants, your mitochondria. And so they started looking at the mitochondrial function. And so it was a very cool experiment that they did. And as you can see here, November 2020, I'm not showing you anything that's recent. This was all done before. It's just people didn't pay attention. And so what they did was they measured mitochondrial function in people with COVID. So they measured in healthy people. This is their maximum sort of respiratory rate of the mitochondria. Here is people with chest infections, so just normal pneumonias, that kind of stuff, roughly the same production from their mitochondria. And then when you look at COVID patients, their production was low. So there's something going on with the mitochondria that it's not producing energy, and that's why people are feeling bad. So they looked at reserve capacity of the mitochondria. You have the healthy people, chest people, slightly lower, but not too bad. And then COVID people, it's just in their boots. And so therefore, when a patient says, I have no energy, it's like I have no power, probably the mitochondrial function is not quite there. Now, what's happening in the mitochondria that might explain this thing in some sort of simple way? So this is the mitochondria. So it's okay. I'm not going to go through this. Okay, don't freak out. So this is what's happening inside the mitochondria. Remember in your physiology classes about electron transport? I'm not going to talk about that. I just want to focus in on one area sitting right here. And this area is the fuel. So what fuel will come into the mitochondria? So as you know, fuel is glucose or fatty acids. So for glucose, you don't need oxygen to burn glucose. And so therefore, no oxygen needed, you burn glucose. Now, it's not a complete burn. So you're left with garbage like lactic acid and stuff like that. So that's why people that run, they don't like to burn glucose because you get the muscle cramps and stuff like that. So basically, if it's your fight or flight, it's sort of like temporary. It's sort of really quick. I'm going to give you some extra energy, but no oxygen needed. Fatty acids, on the other hand, require oxygen to burn, but it's a very clean burn. You're not left with any garbage. And that's the one that you can keep going for a long period of time. So your long distance runners want to use fat burning as their main fuel that they're going for. And so therefore, what does the virus do? The virus comes into your system and it flips it preferentially to burning glucose. And the reason why it does that is that on the way in, it might have destroyed your lung. So therefore, oxygen is not guaranteed to be there. So by flipping it to just burning sugar, that's enough power to keep the plants going so that you can make more copies of the virus. It's not enough power for you to get out of bed, but it's enough for what the virus needs to do in terms of making copies of itself. So it's actually quite smart that it does this. Now, obviously, if after the virus leaves, it doesn't flip back the switch into burning both, now you're in trouble because you're continually only burning the sugar part. And that's why you'll hear people saying, like, I can go for about 2 minutes and then I'm flat out. There's no power anymore. So this is why we think that something like this is happening in the mitochondria, and that explains why the mitochondrial production was so low. Because if you're just burning sugar, you cannot produce a whole pile of energy. Interestingly, this phenomenon has been seen
previous to COVID. It was seen in cancer cells. So in cancer cells that are growing very fast, they outstrip their blood supply often. So therefore, cancer cells have also flipped over to burning sugar mainly because the blood supply may not be keeping up with the growth of the cancer. And so therefore, cancer cells are living on this kind of concept as well. Now, the reason why I point this out to you is because perhaps it's the same flipping mechanism, right? It's the same strategy. Could we unflip that thing, right? So if you look at the virus, and remember I told you viruses just carry a blueprint and they just carry a set of keys. So in this particular virus, their blueprint only codes for, I think, 29 proteins. That's it. Four of them are for structure, the spike protein, the ball, and stuff like that, which means there's, let's say, around 25 proteins that are doing these strange things inside our body. And if we were just to track those 25 proteins and figure out which one is doing the flipping, then we could design a protein or a drug to unflip this, right? And if we can unflip it for this, it means that we can correct long COVID because now you're allowing your body to burn both fuels. But we may be able to also attack cancer cells that are relying on this method to stay alive as well. So in other words, there's a lot at stake, and yet nobody has done this. So I'm hoping maybe some of you guys this weekend in your garage, you can tinker with this thing. And I'm thinking this is good use of AI, right? In other words, what is the switch that flips this over? Or even easier than that, just look at the 25 proteins that the virus makes. And of those 25 proteins, which ones go into the mitochondria? Not all things will go into the mitochondria. And we can do this in an animal cell. It doesn't take a whole lot of time. And then once we know which ones are going in, then we can map those molecules. What are they attaching to? And then build something in reverse so that we can flip the switch the other way. So hopefully somebody smart will be doing this, but 6 years later, nobody has done anything. So I'm saddened by this, and we're using AI to figure out what we're going to cook for dinner tonight. So I think I don't mind using up the world's water supply by figuring this out. So perhaps if you guys know people in high places, we can get this done. So therefore we have this problem, and that's why a lot of the long COVID programs talk a lot about deep breathing exercises. So you do the deep breathing, increase your oxygen in your body, and we're hoping that at some point your body says, I've got all this oxygen and I've got all this fat, maybe I should start burning with oxygen on this side. Whereas if you were low in oxygen, then your body might keep you in burning the glucose side. So therefore flooding your body full of oxygen might be helpful. And somebody's going to ask me, what about hyperbaric oxygen and stuff like that? So there are some small study that says if I give you more oxygen than is in normal air, it may be helpful, but it's awfully expensive. And there is toxicity to high oxygen exposure. So that's why I wouldn't recommend that. But I would recommend people taking deep breaths, like the yoga thing, in through your nose, out through your mouth. And that increases the exchange of air in your down here. Because normally we just breathe up here. So we don't actually exchange all the air here. So slow in, slow out breaths will increase oxygen in your lungs, and therefore you might feel better. And for us, it actually makes you feel more alert. So if you're really feeling tired, just do a couple of those yoga breaths, and that may be helpful for you as well. Okay. So that's why when we look at all these long COVID symptoms, you can see here fatigue is pretty much in 100% of them, and exertional malaise. So when they start going, they just don't have any power. So that might be the explanation behind some of these things. In terms of the brain cell, I couldn't find you a nicer looking picture than this. As you know, neurons use up a lot of power, right? Because they're constantly releasing neurotransmitters, and then they have reuptake to take up those neurotransmitters, repackage them into the vesicles, and then release again. And they're doing this every couple of milliseconds, going back and forth. And so therefore, the mitochondria is really important for your neurons. And so therefore, your neurons have lots of mitochondria around the cell body. And there's a set of tracks that move the mitochondria back and forth to the synapse area. So constantly we're shifting these power plants back and forth. I guess if it's like it's in use, then you have to replace it. I guess that's how it works. So there you have this sort of the little trains going back and forth with the mitochondria. And so, therefore, any change in the metabolism of mitochondria, you would expect symptoms to show up in the brain, and that's exactly what we see with brain fog and all that kind of stuff. That people will say that it feels like my brain is running slow, like there's just no power. It's like running like a 286 computer, like in the olden days. So perhaps this mitochondria story might also explain the brain fog that people are seeing, and so that's why this would be an area that would help people. Again, like I said, we don't have anything to fix that right now. So therefore, perhaps, deep breathing exercises, those kinds of things is the only thing that we have at the current moment. So how do you protect people? Like give them the shield, right? We don't want this thing to come into the body. And unfortunately, I think what happened was that I guess everybody just focused on vaccination, which is very important, right? But then vaccination means that the virus has already entered into your body. And so therefore, now we're just using the second line of defense, which is inside your body. So that would be like, let's say you're trying to protect some famous person and they've already come into the house, right? So ideally we keep them outside. So that's why when we start looking at how does this virus transmit, it's actually quite interesting. It's just basically us talking to each other. And that's basically how the virus goes. So the virus itself, remember I said it has basically just a set of blueprints and a set of keys. It has no mode of transportation. So it has no motors, it has no wings or anything like that. So it relies on us to walk up to somebody else and breathe it out. And it relies on the other person to suck it in. And so therefore the virus is, let's say, sitting in my throat versus my nose. And the reason why I point these things out is that the Delta version liked your nose. It likes your lungs, but it likes your nose. Now, when you have viruses in your nose, you tend to breathe downward through your nose. It's very rare that you shoot your nose viruses at other people. So therefore, going downward, it's actually harder to transmit Delta virus. However, Omicron is sitting in your throat. It loves to grow in the throat lining, and it grows there 70 times more often than Delta. And because of that, every time I talk, I'm blowing out viruses. So if I laugh, I talk, I cough, I'm blowing out virus with every single breath, which now means it's horizontal going out towards you. And so now it's much easier for this guy to suck in one of those viruses because now the virus is actually very close to them. And then they would set up shop here and in the throat. And then we rely on their antibodies to help protect them. So really, when we started talking about a bit of distance, it was helpful so that way the viruses aren't close to you. Now, we don't have to be like 10 feet away, but the idea is that direct line of sight is not good. So we started teaching people, don't stand right in front of people. You'll see, like we were talking to the reporters at CBC, we said just stand staggered. And from the camera's point of view, it'll look like you're still, facing each other, but you're staggered, so your air is not going directly to the people. And same thing when we're sitting across the table from somebody, we just stagger people a little bit off so that way your air is not directly going across. Circular tables tend to be a little bit better because you're all aiming towards the center and there's nobody sitting in the middle of the center. So these were the things that we're trying to teach, kindergarten and grade schools of how to get their kids together without having all these problems as well. You can understand that if I have a mask on this guy, he will not be able to blow out as far. So we didn't really care whether it was leaking on the side or things like that. If the virus leaked on the side, it's staying on your side. So really the important purpose of the mask was to stop you from blowing it out directly, from giving wind power to the virus. And on the other side, if this guy wore a mask, it was really to make his sucking power reduce. So in other words, the virus would have to be really close to him before he can suck in. So the mask was actually protecting both sides. So for the people that had virus, it stopped the virus from coming out further into that common airspace. And for people that were not sick, it stopped them from sucking in the virus. But unfortunately, when we presented it through the public health system, it was basically the mask is when you're sick, right? And then people say, but my kid's not sick. Why does he have to wear a mask? We didn't explain that there was a benefit for the kid if they're not sick, that they're not going to be able to breathe in the virus. So now we're trying to do it a little bit nicer in terms of how we explain these things to people, and perhaps that might be better. Now, what about the antibodies that you're making? So this is where I talk about the thymus to my patients, right? So nobody talks about your thymus. Nobody says, how's your thymus doing these days? So the thymus is where the T cells get trained. And as you know, the word T, the T stands for thymus. So T cells are made in the bone marrow, but they go for training school in the thymus, and that's why we call them T. And so I always tell my patients it's kind of like Harry Potter going to Hogwarts for training, right? So basically that's what they're doing. And so in the training camp, what happens is that these T cells are given a bunch of parts to make receptors. And so therefore they mix and match the different parts, they make receptors. If the receptor is useful, then it is kept. So let's say it can recognize strep or something like that, then that T cell is kept. If it makes a receptor that's not useful, that T cell is killed. And then the other thing is that the receptor cannot recognize yourself. because if it recognizes your own HLA and attacks your own cells, that would be autoimmune disease. So those cells are killed as well. So out of 100 T cells entering, Harry Potter school here, only two of them graduate. So 2% graduate, but those 2% are good, right? Because they've got a receptor that's useful and it doesn't attack yourself. Unfortunately, as we get older, your thymus becomes something like this. It's full of fat. So just like the rest of my body, they did these scans of people in Denmark where they looked at the thymus, and basically by the age of 65, 85% of the people had fat replacing their thymus. So there was no more training. And so this is now what I explain to patients. Your own training center is no longer functional. And that's why I have to step in. So the vaccination isn't because I'm vaccine happy. It's just because your training center isn't training them. And so now you have new recruits, but they don't have a receptor that's pre-built. So if you get a virus, then the new recruit has to figure out what is it that I have to attack, then start making the receptor to do this. And by the time you get that all together, the virus has won. This is a race. The virus just wants to replicate and make copies of itself as fast as it can. Unfortunately, in doing so, it's causing some damage. So therefore, it just wants to live. Unfortunately, it's destroying our body at the same time. And we just want to live, so we need to stop the virus. And it's just a simple race. And so if I give you preformed receptors, then you're going to be able to enter that race sort of full force, and therefore you can take care of it quicker. Otherwise, the virus will outstrip and therefore be problem. And this is one of the reasons why the elderly are such a target, because their T cells are no longer trained anymore. So they have lots of T cells, but they're not trained. And that's why we have to do this. And then I'd always tell patients that I'm not as good as your thymus. Your thymus can train all of it at the same time. I can only train one at a time, right? That's why I have to give you an RSV vaccine and a shingles vaccine and a COVID vaccine and a flu vaccine, right? I could put them together, but I have to put them in separate shots. And that's the reason, is because I can't train your body as well as your thymus can. But I do need to do that so that I give you an advantage, so that when the race starts, at least you've got a decent head start as well. This part I'm going to go very quickly because you guys know all the rules and everything else, right? You probably know it better than I do. So, in other words, here in Ontario, basically anybody over 65 qualifies for a shot. Over 6 months old who are in long-term care, who are medical conditions that put them at higher risk, if they're pregnancy or First Nations, like all of those people qualified. So pretty much everybody qualifies for the first shot. And then healthcare workers as well. So we're included in there as well. And then who should get the two shots? And basically this is over 80 or 65 to 79. I don't know why they separated that out as 80, and they should have just said over 65. And long-term care homes and immunocompromised people that are over the age of 6 months, then you can get two shots. So that's pretty straightforward. You saw the dandelions that are going around. So I always tell people the virus is kind of like a dandelion. It's growing really fast. It can go out of a rock even, right? And so therefore our job is to stop the dandelion as quick as possible. And we want to stop it before it becomes that little white ball and then sends it around. And I think patients have that good visual image of dandelions spreading all over the place. And that's really what we want to do with this virus. We don't want it to wander out throughout the house as well. And so basically, I don't explain all the time this thing, but this is how I explain it to them, to the other, family docs and stuff like that. So basically, you have the virus making a copy of itself. And as you know, the blueprints will make this long choo-choo train, this protein, and it's just one complete long choo-choo train. And then you need to cut it into the parts. Okay. So therefore, there's a pair of scissors that will cut them, and then it folds up into the parts, and then you can assemble. But the whole virus comes out as a long choo-choo train. And so basically, the protease is the pair of scissors. So the idea is that we want to block the pair of scissors. So this guy blocks the pair of scissors. So that's very good. And so therefore, when Pfizer came out with this thing, they say, block the pair of scissors. You're still producing the choo-choo train, but there's no parts to assemble into a virus. And this could buy you time, right? So that your immune system can ramp up and then mount a defense. And so therefore, it was a great idea. The only problem is the drug only lasts for a couple of hours. So it's too short, which means it's an intravenous type of treatment. Now, that's a big problem because at that time, we didn't want anybody going into hospital, let alone going to hospital to get an IV treatment to prevent, all this kind of stuff. So what they said is that if we can block the elimination of this drug, that would be helpful. So ritonavir blocks the 3A4 cytochrome. This thing goes out through the 3A4 cytochrome. If we block it, we can now keep the drug in your body for longer. Then we can keep it there long enough so that we can just take it as a pill form. And then you can just do it twice a day. and therefore people can stay at home. And then we can show that you're preventing hospitalization, right? Because if you have to come into hospital to get the intravenous, what's the point? You're sucking up beds and everything else. So by making it oral, they basically did this. So it was actually a very smart strategy to take a drug that needs to be given intravenously and then make it into an oral formulation. Unfortunately, you're blocking the 3A4, which is a fairly busy pathway. So therefore, other drugs might be affected by that. But then I tell people, you know what? This is trying to stop a disease that might destroy you. So it's worthwhile, right? In other words, if this was a drug to stop allergies, I would say if you block other drugs, I'm not going to use you. But in this case, we're stopping, possibly death, possibly hospitalization, and these long COVID kind of complications. And as you know, this is the cytochrome system. Here's the drug coming through the pathway. Here's the guy that we're giving ritonavir that's going to block the 3A4. Therefore, the drug stays longer inside your body so that you can take it as a pill form. And so the Liverpool people were very good. They put together the drug interaction to try and help us out. And it was a horrific table, right? I think you guys remember seeing this thing. And when I looked it up, I said, every drug that I know is on this table. And then I started looking at it. I go, how come there's green ones here? Like, what does green mean to you? Well, green means no interaction, right? So if you look it up, green means no interaction expected. Yellow means weak interaction, no action is required. And even this orangey peachy stuff, potential interaction managed by consulting patients. And then what do you do for all these three colors? Well, you just proceed, proceed, proceed. In other words, you would still just give the medication, and there wasn't a whole lot for you to do. So I thought this table could be made a lot simpler if we took out the drugs that don't have interaction. And it's kind of strange that we put in no interaction things inside an interaction table, and that's what makes it so large. So I went in there and I took out all the ones that are yellow, green, or this peachy color. And now you're left with these ones. And these are actually fairly reasonable to look at, right? So you can look at it going, okay, NOAC, that's an important one. So therefore, if you're on a Pixaban, what do we do? Oh, you cut the dose in half, go to 2.5. That doesn't seem too hard. So even in the red ones, there is things that we can do now that the Liverpool people have been recommending, and they've got a website and everything else. So by doing this, I was trying to show our family doctors that it's not overwhelming, and then we also have the backup of you guys so that you guys are checking all the medications and things like that. And so that was very helpful. And I told some of our family doctors, why don't we just check ahead of time, right? When they're coming in for their diabetes checkup in the summer, I'll just quickly look at the list of drugs. They're not on anything weird, so I know this patient is going to be okay to use. And then I can tell them, look, COVID is going to come up, flu is going to come up, get one of those test kits, right? And you can check yourself if you get sick. And then therefore, depending on what it shows up, if it's flu or if it's COVID, then there's medications I can give you. Many patients don't know that there's medications. And so therefore, I need to tell them that there is therapy. In the beginning, we told them, don't come to our office, go to the hospital if you're about to die. Like, it was a horrible message. But now we should tell them, if you have the little test kit, you can check right away. And that way we can get the medication in there as quickly as possible. And I know, like, for flu, it's 48 hours. And for COVID, we say 5 days. But do I really want to wait 5 days? Not really, right? Because I would like to stop the virus from going into any other room in your house. So the quicker we can get that done, the better. Right now in my office, basically what happens is a patient calls up and says, I'm sick. And I go, do you have a test kit? No. Go find a test kit. So then that's 2 or 3 days delay. So if we have this preemptively done, then everybody knows what to do. There's no mad panic. People get treated well. A very sad story. One of my partners in the office, dad got COVID on probably the weekend. He was trying to look for Paxlovid. Pharmacies didn't carry it. And then by Thursday, we got an email that his father had passed away from COVID. So stuff like this still happens, right? So therefore, if we have this sort of pre-plan, then there's no confusion, there's no scramble near the end. Now, what about old people? We always say older people, and my friend's dad was 93. He was old, but he was still moving around. Like, he wasn't old like nursing home old, but he was old. And we always say older people at risk and comorbidities increase the severity of COVID. Now, why is that? Part of that we already explained, right? The thymus, you don't train your T cells, therefore you can't mount your response as quickly. But there's other reasons for this as well. And I have to bring in my Starship Enterprise. I hope there's some Star Trek fans out there. And you'll remember that the Enterprise has this self-destruct sequence, right? This auto-destruct. We destroy the Enterprise every movie, right? And basically, if it's been invaded by the Klingons, you'll destroy it. If it's badly damaged, you'll destroy it. Our cells also have an auto-destruct sequence as well. So when it's badly damaged or it's infected, then it will destroy itself to make sure there's room for new cells to come. So this is a good thing. This is getting rid of bad cells along the way. So what happens in our elderly and we put COVID and comorbidities together? So let's say you have a damaged cell. Okay, that will trigger the auto-destruct sequence, right? Now, how does the body know that it's damaged? It's measuring these things called damage associated molecular patterns. Now, that's a mouthful to say, so they call them DAMPs. So, in other words, if there's a lot of DAMPs inside the cell, then the body will say it's time to get rid of this particular cell. If you're old, you have more DAMPs just because your cells have lived longer, therefore, you're going to have more DAMPs. If you have comorbidities like cancer, diabetes, hypertension, you will have more damaged molecular patterns there as well. So you'll have more DAMPs. So because you have more DAMPs, then you're more likely to call for auto-destruct. Like in other words, you're really quite high already. Infected cells also can call for auto-destruct, right? And so this one, it's measuring pathogen-associated molecular patterns. So again, just to be cute, they call these PAMPs. Okay, so if you have lots of PAMPs, then like SARS-CoV, lots of viral proteins sitting there, then your PAMPs increase as well, and therefore you increase the chance of calling for an auto-destruct. So that's why when we put the two together, you put elderly with comorbidities, lots of DAMPs, and then we put them together with a virus that replicates pretty quickly. You now have lots of PAMPs, and therefore you have very severe COVID because you're asking for the body to destroy cells. Now, it's fine if you're destroying one or two cells, but let's say the virus infects 5 million lung cells, then 5 million lung cells will call for autodestruct. And so the army will come over here and then it will destroy it. This you and I know as cytokine storm. So cytokine means cell movement. So cytokines are chemicals that we call the army over to come over and destroy. And that's what the cytokine storm is all about that you hear. And that's why it's very severe COVID. We saw this in the original numbers from Wuhan. And this was the death rates early in the infection pandemic. And you can see here somebody with no medical condition, less than 1% death rate. If you have cardiovascular disease, it's 10%, so it's 10 times higher. And if you can see that, diabetes, COPD, all of them are 6 to 7 times higher. And that's because they had more DAMPs. So it's easier for them to trigger. So I always tell my patients it's kind of like a speedometer, like a speed dial. And so therefore, let's say when you hit 80, you redline and then you call for auto destruct, right? And so basically, if you are old and if you have comorbidities, you're already up to here already. So already there's enough signal towards that auto destruct. If I add in some viral particles in there, now I take you the rest of the way, and then this is what will trigger the auto destruct. And so that's why we spend so much time talking about distancing, sort of don't breathe in the virus and all that kind of stuff. And I tell my old grannies, that want to give a hug to their kids or grandkids, I go, just don't suck in around the children, right? Because the virus needs you to suck in to bring it in. So I tell them to hold their breath when they hug, right? So when little Johnny comes in, just don't breathe. When I told them hold their breath, they go like this, and that looks really funny, right? So I just tell them just stop breathing, and then as soon as Johnny's over here, then you can breathe all you want. And then as soon as he's about to let go and pull away, just don't suck in. And therefore, you can reduce the chance of picking up the virus. And whenever I examine a patient's close up with the eye thing, I always tell them, you hold your breath, I hold my breath, and the virus can't move between us. Mask is if I'm going to be sitting really close to something, if I'm operating on somebody, I need a mask so that it slows down my sucking ability. So therefore, the virus has to be really close to me before I can suck it in. Vaccination, once it gets inside, I need the training. So therefore, your T cells can mount a response. And then if you get symptoms, even though you're vaccinated, you've done all that stuff, it means the virus has entered your cell, in which case we need antivirals to stop it. So we want to stop the replication, even though it's only for 5 days, it gives your immune system a chance to catch up and therefore put up your defenses that way. And we don't want this thing wandering around through all the different houses and setting up shop. So this is sort of the pathway that we need to do in order to fix all of these patients so that they don't get into trouble. So stop the virus from getting in and then defend based on antibodies and antiviral as well. So once we can stop that, then we can move the curve back to here, then no more auto destruct. Yeah. This is a very funny label. I think it's from China. Anyway, it says this, remove child before washing. So I'm not exactly sure what bad thing happened to the child, but this was very bad. So how do I simplify things, And the way to simplify it is that ACE2 keeps things normal. That's the peacekeeper. COVID uses ACE2 to get into the cell, And without the ACE2 sitting on the cell surface, the repair process goes wild because it thinks that you are in terrible damage, and then you get lots of inflammation and scarring. So what do we do about it? Don't let the virus in. So do the distancing and the mask and the holding your breath and stuff like that when you're trying to get the hug. Vaccination increases your body's training of those cells, so therefore you have antibody defense. Antivirals, especially for the elderly and the comorbid, they won't be able to fight it off. So if it breaks through all of it and it still gets into the cell, so they have symptoms now, then we need to stop the replication of the virus and therefore give the immune system some time to get organized. And a little bit of pre-planning is helpful because as soon as we hit the flu season, we're going to be scrambling again, right? Because you guys will be busy with vaccinations and everything else, and everybody's back from school, so they all want all their prescriptions renewed. So in other words, you will be very busy. So this is a time during the summer where you see the elderly people, 65, diabetes, COPD. Those are the people who say, hey, I know it's early, but let's just plan about the fall. Make sure that you get a test kit. The test kit will check for flu or COVID. There are medications for that. Just those words, there are treatments for that, is very helpful because now the patients know they don't just lie at home. And then, so therefore, when they do have their test kits, if they test positive, then you know what to give them and you will be able to help them. Like if all the doctor's offices are closed, you can help them. The only extra thing that you need is the EGFR. So I've started actually, writing it down or taking a photocopy of their last lab. So I've been telling some doctors, like, if you really want to prepare, just make sure that you have a little photocopy of the last lab report. So the EGFR is 80. You don't have to worry. If it's below 60, we have to give a different dosing, and that's it. And then as far as their list of drugs, I tell doctors now, just have a quick look and chances are they're not on any of those crazy drugs, in which case we don't have to worry about those drug interactions. And even if they are on it, like let's say they're on apixaban, we already know what to do. So it's no longer a scramble at the moment of a phone call and you're trying to look up everything. We can actually do this ahead of time. And at the pharmacy level, you guys are amazing. You can do a lot of this stuff because the pharmacists, the patients trust you guys way more than us. And so therefore you can also help with this messaging of sort of pre-planning. So therefore there's no scramble and giving them the advice about hugging and all that kind of stuff. The other one is in an elevator. They always ask me, elevator, what are you doing in an elevator? I say, just be antisocial, turn and look at the wall, and then just tilt your head down. So breathing the air here, it's very hard for other people's air to get in front of your chest. And so that's a good one. And when you're on a trip and you're getting up to get your luggage, just don't face anybody. Because when you're standing up and you're facing somebody waiting to get your luggage, that's a good way to breathe in the virus as well. So simple things like that. I think patients kind of appreciate it because it shows that you care about them. And it's something that I haven't heard about. So if you give that messaging and then you tell them, hey, there's a test kit and there's treatments, then the patients say, this I can do, and thank you for, pre-planning with me as well. Anyway, thanks very much for staying awake, and sorry I droned on for so long. Let me just stop sharing my slides.
Thank you so much, Dr. Lin, for taking the time to talk to us about this, which I'm hoping a lot of people have learned a lot about this because I feel like since the beginning, we're kind of set in one at that time,
Yes.
what was known about COVID.
Mhm.
Obviously, there's been a lot of development since, so it's really important to continue to share this information so that everybody knows because, and as you point out, there are treatments that can work.
Mhm.
And also the prevention aspect is also still just as important, especially for people who are at risk for severe COVID. So thank you so much. I'm just going to check the Q&A here. We have someone's asking, is there a new test kit? Um, I don't think it's new. Maybe I can take this, Dr. Lynn, for just from a pharmacist perspective. So pharmacies have access to the rapid antigen tests through the Ontario provincial, I think they call it provincial antigen testing program. So you can still continue to order those through that program, available free of charge to everybody that you can give free of charge as well too, kind of handed out ahead of time, as Dr. Lynn suggests. It's not a new test, um, and that's a rapid test. I think many of you might be aware that the PCR testing program is no longer available for pharmacists, so that was discontinued just earlier this week, actually. So the PCR testing is no longer available for pharmacists for accessing that program, but the rapid test is still available.
Yeah. And then there's the one with the two tests. I just saw it at Costco. They were selling like whenever Costco is selling it, it's like they figured out there's some sort of market there. And so that one also, and it was, I think at Costco is like $15 for five. So it's about $3, which I think for people at that price, it would be worthwhile. But it's something that nobody thinks about, right? Like you're in the middle of summer. What are you going to think about these kinds of things, right? But then as soon as we hit the fall, we're going to see it go up again. And I'm worried that if we sort of are kind of lazy about stuff, it becomes a problem in the fall. So the idea is that we don't
Mhm.
want a big, huge bump up again and have problems this way. And so anything that you guys can do to talk about this now, people will be prepared.
And that's why we're having this webinar now.
Okay.
Trying to capture ahead of time, be prepared, basically. Are there any other questions for Dr. Lin? Okay. Well, if there isn't, we can end a little bit early. I want to thank Pfizer Canada again for supporting this educational webinar. And also want to thank you, Dr. Lin, for taking the time to speak to us and for everybody who's attending tonight to this afternoon, not tonight, for your time in attending this webinar. Oh, wait, we just have another question come through. Oh, first one, is there a different variant in the vaccine?
Yeah, yes. So there's going to be the fall one. And then again, as you know, we're always chasing our tail. Okay. And the thing is that the tip will change a lot, but the bulk of the protein is still the same. So the actual spike protein is 1,271 amino acids. And you'll hear them saying, oh, three changed or 50 changed this way and that way. But the bulk of it is the same. So we think that some of the benefit is when you get the shot is that you are making antibodies against the common part. Right? So in other words, the tips are changing, but maybe the common part is staying the same. And so your body will say, I recognize that part. I'll start making antibodies. So that's why when we were in the beginning, we were tracking very closely. So if I give you a Delta shot, it was actually covering the Wuhan version as well. And so therefore there was these cross benefits. Having said that, we realized that for young, healthy people, if we're using the marker of hospitalization as the goal, then we're not going to see a reduction in hospitalization. So that's why they started saying, well, if you're young and healthy, maybe the shot is not as important nowadays. But for your elderly and for your people at high risk, they still need the extra help. And I think that's why they're still saying that. And that's why there's two shots for them. That would be the spring and the fall. And basically, the World Health Organization keeps tweaking it as we move forward.
Thank you. The next question is there any benefit to wearing a mask on duty while working?
Yeah, it depends on how close you are to the patient, right? So let's say you're sitting there and you're counseling them for, 20 minutes or something like that, or they're standing there. You know how some people sort of spit at you? Well, that there would be some benefit there. I've noticed some of the pharmacy, like our pharmacy, they've kept the glass up. So therefore they don't like it's horrible for you to wear a mask all the time. But if you're, let's say, in the back of the pharmacy and you're just processing things off and you're not in front of people, then there's no need. But I've noticed that some places they've now just kept the piece of glass there. And so therefore people are used to it. And so that's another way. But wearing it all day long is very difficult. And perhaps what you can do is just wear it when you're close to the patient. And then when you're in the back, you don't have to wear it. And that way it cuts down on sort of fatigue from wearing the mask.
And we have one more question here, which I think we'll have just on time now. Can COVID cause mast cell activation syndrome?
It can. It can. I didn't talk about that. So basically, the immune system can go crazy, and there are many things, and that's why there was some therapies like using Rupall to stop the sort of the platelet activating factor and also histamine. So for people that get rashes and stuff like that, hives, antihistamine is one of the treatments for them. So basically, your immune system doesn't know what's going on; it's become overactive, and so that's one of the long COVID kind of symptoms that we see. One of the reasons why is that the T cells also have the ACE2 receptor on it, right? And so, what happens with the virus when it goes into your lung cells, it not only makes the virus itself inside the lung cell, it makes the spike protein on the lung cell. So the lung cell has a spike protein, and that spike protein can attach to the neighbor's ACE2 on a healthy lung cell, and you get a giant lung cell. Okay? Now, that giant lung cell now means the virus can replicate inside there, and it's very hard to attack a big lung cell. So when the T cells come, there's spike protein on the lung cell, but there's an ACE2 on the T cell, and they actually attach together and the T cell gets sucked into the lung cell and gets destroyed. And it turns out that the T cells are also getting destroyed in this manner. And that's why in the original Wuhan, we had low lymphocyte counts in these people. You normally expect high lymphocyte count with a virus infection because the T cells were being eaten. Now, you can imagine if I eat away your T cells, I'm now messing around with your regulation of your immune system, right? So let's say I eat away your T helper cells, then they're not there to direct the immune system. If I eat away your T cells that attack strep, then you can't attack strep. So that's why the immune system is being affected because some of the T cells are getting messed up with as well. And that's why we're seeing some of these outbreaks of strep and measles. And we blamed it on no vaccination, but we never had a vaccine for strep. And yet we had a strep outbreak. So which means that it's something going on with your T cells as well. So keep your eye on that space because I hope some smart people will study it. But the problem is right now the funding is all dried up, right? Because nobody cares about COVID. So these poor patients with long COVID, unfortunately, I don't think there's going to be many studies on those ones.
Thank you so much. Once again, now we've run out of time for sure. Thank you again, Dr. Lin. I think that, I guess, basically the key message here, we learned a lot about the how. And then the takeaway, I think, for everybody is just be prepared for this fall, have some tests available, have treatment available, have Paxlovid on hand so we're able to kind of help those that we can sooner than later. And thank you again for joining us. Thank you to the audience, and thanks again for Pfizer. Have a great weekend, everybody.
Great. Take care. Thanks very much,
Thank
Kathy.
you.
Bye.
Bye-bye.